because they keep it in their mind. All the slices they run through, they have an idea about this is going to be the tumor. There is no tool which clearly says, help them to identify this is the tumor size, this is the tumor volume. If you start viewing this, they don't know anything, everything in mind. So that's the way all these years they are doing, because there is no company has given a dedicated solution for them to do this procedure. So if you look at like most suitable in nobody. So if you look at liver surgery, if the patient is not in a good health, you can't do surgery. Whereas for ablation therapy, you don't need to be in so good health. Even if the patient is in a reasonably okay condition, because the procedure is 1 hour, it doesn't take so much stress on him. He doesn't need to have post-treatment for 2 weeks or anything. And if you look at the trend on the interventional oncology, if you look at ablation, is getting better, 15 to 18% US, Europe and Asia. Surgery is very low, tears and tears. So overall, if you look at it, is an acceptable practice of interventional ablation procedure. And also, if you look at the survival rate, after you treat, you want to see how many years they can survive. If you look at the radiation 11%, chemo 23%, whereas ablation is 60%. So if you have a liver cancer, if you are using ablation as a treatment or a therapy technique, there is a 60% of probability people can survive beyond 5 years. And also if you look at the expense, the cost is just $3,000. It's close to 2 lakhs rupees. Whereas if you look at surgery, it's $200,000. I think this is US data. $200,000 is, anybody knows how much $200,000?
More than 1 crore.
1.2 crore in US to do a surgery of the same nature. And again, I talked about this ablation, no visualization available, no planning tool available, all guesstimate. So that's why I told the huge variation between doctors to doctor. The same person, if is treated by 3 doctors, probably 3 doctors treated in a 3 different way. So that's where robotics help have a consistent, either right or wrong, it will be consistent. And these are the kind of procedure to do that. First, image the patient, see the tumor and plan intervention, navigate the instrument and perform intervention and verify the treatment. Today, the biggest challenge is if you go anybody treated, they ask them to come back after 4 weeks to 6 weeks. Why? Because they want to see any tumor they left it which is grown back. Then again the life starts. After 6 weeks they will tell, come again for a treatment, again 2 lakhs rupees. Whereas in our robotics, once you finish the procedure, you have the image processing technique, it will confirm whether you fully cured the tumor or not. So you don't need to come back again. And it's just some of the product for interest. Some of the things we are also working on screening. The very important thing is, now you allow the tumor to grow big, after that you go for treatment. So you want to screen and see that whether the people having a potential, they can have a tumor or not. I think this could be an interesting project. If any of the students are interested, you can work with us. We are working on 2 particular screening devices. One is oral cancer screening, other is cervical. In India, close to 134 ladies dies because of cervical cancer. And it's not a very difficult procedure. I don't know how many of the girls here know what is cervical cancer. How many of you, please go and read in Google, and please help your mothers or sisters or whoever it may be to do a screening. Because many people doesn't know this. And very later stage they come, we cannot say. Like the breast cancer. It's not kind of very difficult to detect. But many people, as a culture, we don't go for screening. So we are working on screening for cervical and oral cancer, especially Tamil Nadu, Andhra, Kerala. There are a lot of people affected by oral cancer because of chewing, smoking and all this stuff. And we are also working on a very smart probe to help you to find out whether it's a tumorous or non-tumor. So we can put the probe into the same instrument, it goes inside, it will tell you that immediately whether this patient is a cancerous or not cancer. If he is cancerous, just to take out the probe, put the RF gun, you burn it. So we want to bring the total diagnostic to treatment in 4 hours. A patient suspected for cancer comes to the clinic 8 o'clock, 12 o'clock he can go get cured. It's a very simple goal for us. These are two products in the market. If you go to our website, you have more videos and more information on that. So what are the challenges? When you want to do a robotic device for surgery or any application, what are some of the challenges we face when designing? The first one is the registration. You have a robot, you have the image, you have the patient. How do you register all the three people? You need to have a common coordinate where when I say that liver, this particular portion of the tumor is here, how the robot will know exactly the spatial coordinate. You have a CT scanner which takes the CT image. You have a robot which is standing outside, the patient lying on the bed. So unless we connect these three, we cannot perform exactly the required surgery. And that's a big challenge for every procedure. The second one is interoperator registration. You think that when you take in this image, the patient in particular orientation, you assume by the time you start the surgery, the patient will change its position. You don't know what happened. The third one is segmentation of organ and critical structures. You may want to go to liver, but you don't want to pierce through gallbladder or diaphragm or your kidney. So you must find out where these spots, when you are doing a procedure, you have to segment those and you have to tell your robot, please do not go through this. Then patient stability and physical orientation. I talked about patient can change its orientation. That's a big challenge for that, because a small change, we don't know what are the organs, which position is they shifted. Respiratory motion, people breathe, the breathing always, all organs are moving. So how do you know that the point which you want to treat is not moving? So we need to continuously find a way to track where this particular point is going. This is exactly CyberKnife is doing. If you look at for radiotherapy, the standard Linac will keep on giving you make a mask and open the portion where you want to send the radiation. But the organ is moving. So CyberKnife what it does, you put a gold particle in the inside, it keep on tracking how the gold particle is moving back and forth. It knows which are the time it comes to the position, it will give the radiation. So you don't radiate other part of the organ. So similarly, this is challenge is patient respiratory motion and post-procedure verification. You do all these things, patient goes back after 6 weeks, he got the tumor again, the life is so sad for them. Come back again, spend few lakhs rupees. So these are some of the challenges when we design robo we encounter. So a registration, we have two types of registration. So one is I talked about the robo, the patient and the image. The other one is you contrast enhanced image. You all know about contrast? All sleeping? So you know contrast, right? So the contrast will give you a better detail about the tumor. But the day when you go for a surgery, we take a CT scan. You cannot give a contrast again to the patient. So you take the old contrast information and do image processing and superimpose with the current image. You know, we might have studied elastic registration. So we do the elastic registration. So all the deformation we take into consideration. The same deformation we apply onto the image and we get the exact location where the tumor is there. So this is, we do the registration. Then we get all the views. We get the axial view, coronal and sagittal views of this detailed image. Then you do the, this is the segmented, the segmented vessels. Here we segment the liver, we segment the vessels, we segment, you can see that the golden color is our tumor, we segment the tumor. So we know exactly what is the orientation, what is the volume, how much energy you have to apply to burn those things. And these are the probes, you can see the color probes which you can insert. So that will cover the total volume. You can see this here, the green volumes, which is the ablated volumes. Inside is the tumor. So you can see the tumor here, with all the tumor we insert from externally. And this is our robo. We also see robo with respect to robo where those tumors are there. And you burn it. And you take intra-operative verification, whether the patient's any movement or anything you want to corrections. You can again superimpose the image and do that. And this is the, you look at the blue one, this is the verification. You can see the tumor inside, this is what we planned, whether the tumor is fully ablated or not. So we do a verification of those things, then we find, okay, now the volume ablated is fully covered the tumor, we can ask the patient to go. But if you see it is not effective, then ask the patient to stay back and put another needle and you can ablate. And give the report. That's pretty good. So key benefits we look at from our experience, we are taking lesser time, we have a less exposure to the patient, cost is minimal, no complication. If you look at, not even reported one complication so far. The pneumothorax is less, your pneumothorax, right? When you insert the needle in lung cancer, the air comes out, the blood comes out with that, or we cough the blood, it's a complication, we don't find a complication. The reason we recommended a best practice of anesthetize the tract, so that's why the patient feels comfortable. So we got all the, probably the first Indian company got all certification, from US FDA to, you name any certificate, we got all the certificate to sell the product. You see that the world's most of the best hospital is having our robo to treat the patients. Chennai, you can see, global hospital you can visit, you can see that. You have multi-super specialty hospital. You know that the secretariat which our chief minister converted as a hospital, you can visit there, you can see our robo. So you can see it in Mumbai, Delhi and all the places. So we have 5 patents, US patent for our product we have. We also, some of the patent, we also license for our ultrasound product. This is a kind of competitive landscape if you look at it. So we are coming with all the patient imaging to patient verification. This is some of the competitor. So this will give an idea for people like how the trend is today. So there are pockets and there are people like Perfint. Philips is very close to us in terms of offering solutions. These are our clinical affairs I talked about. We work with the clinicians. So we have Europe, US and Asia. This is the team. Most of us, we work more than 20 years. Most of us from G Medical System. Couple of them from Mindray, Siemens and Philips. This is our team. I thought then I can screen those things. I think it's more analyze your blood. You can know your oxygen levels. You know your blood pressure levels, right? You also know various other parameters, you can get that one. What is interesting is we need to work on developing more algorithms on this. Because it's also, if you look at how the patient responds to in South India and North India is different. So that's the reason the local doctor, if the month of July and August, if you go to that, you know what kind of disease will come, right? Because in the last 20 years he is treating, so he knows this is possibly will happen. He won't go to all the blood tests immediately give a medicine, right? So I think these are the areas, probably like we can combine robotics, we can combine this kind of algorithms, you can develop. You can reduce the variation as you talked about. You don't need to go and give the combination of medicines and she have a side effect.
So actually, I know that these kind of things are done using a knowledge base. When you are using artificial intelligence, we use a knowledge base, and that knowledge base is created with the knowledge of some physicians, as far as I studied. So, sir, is it possible without the involvement of physician knowledge or knowledge base, can we create certain cognitive skills in a robot that this kind of thing can be generated by a robot himself using certain algorithms?
I think, see, who is defining the Robots Act is the people. So how are you defining that one? This is based on the knowledge available. Okay. What other things we can use it instead of going by individual's experience? You can combine individual experience. You can also do a lot of data which you are acquiring there. Then you bring a kind of a combination of information, the data information, knowledge information, and all you put together you develop. Then you keep teaching your robot. Based on the case by cases, you use the robot's kind of prediction versus what is actual. So if you keep on doing it for a few years, then probably you have the robot has a better knowledge by giving the input, will tell you this is your problem.
Alright, sir. So can you throw some light on some neuropsychological disorders using robotics?
Yeah, you can do a lot of things. Either you can use for treatment. The treatment you can use that. This again, it's also like if you look at it, it's only about programming, right? But you can categorize what is the type of disorder, what kind of treatment is required. One good thing about robo is it will deliver consistently what you are saying compared to the human being.
Right.
It works 24-hour basis.
Correct, sir.
If you need a kind of a support needed to a patient who suffered by this one, this is available 24 hours basis. Not only that, it also can send information to the consulting physician to take a further advice. So that way you can have this kind of, actually speaking, you can replace all these people with the robots for taking care. And instead of like you can have a central robot more knowledgeable. These robots can work on a specific task. When they don't know what to do with that particular incident, they can have a camera, they can see how the patient will behave. They have audio which know what they talk, what kind of noise can come. All mobility, you can have sensors. When this robot doesn't understand this particular behavior, it can connect to the central robot to ask. To minimize the cost, why I am telling is, otherwise every robot I keep adding to that, probably it will go in crores. You buy a robot which is few lakhs to take care of somebody. A particular instant base, it can send an input to the central robot. So that will feed him how to behave this robot. Right? So I think more and more if you look at it, the knowledge base, the database and everything with the connectivity, all these things, I think the more of the patient can be given by robots better than human beings.
And so one more thing, there you showed that in a CT scanner, first the robot is like pinning some kind of pins or needles inside the patient,
Yeah.
and then again the patient is exposed to a CT, and again we are bringing it back and